Well, I know folks are trickling in, but it is exactly 1 o'clock here on the East Coast. So we're going to dive right in because we have a lot to cover in a short period of time. And this is a conversation I am really excited to host today. My name is Courtney Pladsen, and I am the clinical director at the National Institute for Medical Respite Care. It's a special program through the National Healthcare for the Homeless Council. And today we are so excited to be joined by Dr. Abraham, Dr. Bhalla, and CEO of Illumination Foundation, Paul Leone, to share with us a data-driven analytical approach to Illumination Foundation's integrated care model for people experiencing homelessness. And I'm particularly excited about this, not only because respite is near and dear to my heart, but one of the things that we were mentioning before we came on is that so many people who are doing this work in medical respite programs know and have seen how these programs are transformative, how we see how people's lives have been saved through respite and how people exit homelessness through the intervention of respite. But one of the things that we are really missing in this field is some of these data-driven analytical approaches to know where we should invest our resources with the most impact. We want to make sure our programs are financially sustainable, that are improving outcomes, that we're decreasing disparities, and we need that to be data-driven. And so we're just so grateful for Illumination Foundation's leadership in this work. They are so just doing such amazing work. We have things to learn from them. So we're grateful for the time that they're sharing with us today. So we are joined today with 3 speakers. Ashish Abraham is a physician, the president and co-founder of Foresight Health Solutions. Paul Leone is the president and CEO of Illumination Foundation, and Pooja Bhalla is the executive director of healthcare services from Illumination Foundation. So we're going to just dive right in. We're going to hear from them, and then for the last 10 minutes, we're going to open it up for question and answer. So I encourage you to put questions in the chat throughout the presentation, and my hope is at the end that I will bring up those, I'll share those questions with our speakers today and respond to some of the questions that you may have. I am going to turn it over to you all. So thank you so much.
Thank you, Courtney. And we're so glad to be with you here today. Our relationship with the council goes back quite a few years when medical respite was just starting to take hold, especially in Orange County. We were working at the time in a motel and just got connected with the council and realized, wow, there's other people that are doing similar work. And we just followed what other people were doing and networked. And so I'm happy to be here today with Dr. Abraham and Dr. Bhalla, because I kind of weaseled my way into this presentation. I'm the kid in high school, or actually junior high, that would raise my hand right before lunch and say, you know, you lost me at XY axis. And so all the rest of the kids hated me because statistics and math were not up, they weren't a priority for me. And I kind of think that many of you are in that same boat with me. I know there's some of you out there that, wow, you just get inundated with data when you hear data. And so, and when you start seeing all the metrics, and if you're in that group, then that's why they allowed me to come on to kind of set the stage, because they always use me as, show Paul, if he understands it, then everybody else will get it. So, you know, for those of you out there that are statistically challenged like me, you're in the right place. So can you switch over to the first slide? So when we started back in 2007, we actually started in a armory and a hotel. And so we did what most of you had done. We were treating the individuals that were in front of us. We were providing wound care, health care, infections, mental health, substance abuse. And this is what it looked like in 2007. So as we were administering care, it did not become apparent to us that we should be gathering data and statistics. And to be quite honest with you, when we were treating our clients, you know, they wanted us to stop the bleeding. They didn't want us to ask them how they felt about bleeding or can you fill out this form. So we just were seeing patients doing what intrinsically came natural to us as providers. We were doing nursing, and it worked and it got people to a certain level. But then what happened with many of you and many of your organizations, we had insurance companies start to talk to us about funding and about, we need more data. And so not knowing a lot about data and other than just the obvious, we were giving them anecdotal stories. And I'm sure most of you have become really good storytellers by now because we have the stories, we have the people. And so what happened was they would continue to come back. And as we grew, we started, our budget was probably about 2 million when we started. It is now 50 million. So went approximately 50 million. So as we started that continue to grow, we were having not only ACOs, but insurance companies, private insurance companies, payers saying, we need more data. You have to have a data-driven approach. That's all and well. I mean, that made sense to us that we needed to do that. But two things that happen is how do you get that data and what do you do with it? So probably for about 3 or 4 years, we really struggled with, okay, we have this enormous amount of data that we were collecting. Our poor nurses, social workers, and site assistants were trying to document everything they could. And so we would have these periods where we could go, okay, we have the data, but it really wasn't telling me anything as a CEO, other than we have a lot of people and there's a big need. And I think we're saving quite a bit of money. And then along came Dr. Bhalla and Ashish and really started putting meaning to that, data. And so next slide, please. So we started to grow and we started to see that we can make that case not only for healthcare, but housing. We realized that many of our clients, yes, they needed healthcare, but they were unstably housed and they couldn't receive the healthcare unless they were housed first. So we jumped on that immediately and started doing housing as part of our continuum. And this is our current continuum from street to home. And so while we implemented all these processes, we were even asked for more data. People were coming to us and saying, great, now you're taking care of thousands of people, but how are you making the case that you really are hitting the quadruple aim? And so when we started with really analytically looking at our programs and with the help of Dr. Abraham and Dr. Bhalla, we then got to a process that, number one, we were collecting the data. Number two, we were able to analyze the data. And then the third part, we were really able to make a better case to ACOs, insurance companies, and private payers that you need to do this because there is a return on investment. And as soon as we did that, we got immediate response and quite a few more contracts. And so I'm here to tell you that data works. You really can understand it. We're blessed to have Dr. Abraham able to really explain data and how it really reflects on our program. But more importantly, what do we need to change in our program to give better care? And I never thought, back in 8th grade, that I would be able to take that information, make critical decisions about our business and our programs, and give better care. So the one thing I wish my 8th grade teacher could see me now, because he would really be impressed. And then the next slide. So before I just turn it over to Dr. Bhalla, I'm sure most of you work in these areas, and I can tell you that making the case for medical respite social determinants of health are so crucial right now, because obviously we know there's federal funding coming down in many of the states, and that if we cannot show that we're hitting that quadruple aim and that the return on investment is there, in addition to our satisfaction rates for our clients saying that, yes, they can see and feel the effects, I don't think we'll be able to grow into what we really need to do as an organization and as a way of providing healthcare and housing to the most vulnerable groups we work with. So again, I'm just so proud to be working with Dr. Bhalla and Dr. Abraham, and I know you're going to enjoy their input and, more importantly, really understand what they're talking about. So Pooja, over to you.
All right. Well, thank you, Paul. I want to start with first thanking the National Healthcare with Homeless Council and the National Institute for Medical Respite for hosting us. As we now share with you this white paper, which really captures the system of care that we built, that Paul just described, how we started early on trying to deliver services to homeless individuals in a fragmented healthcare system. So after this presentation, the council will be disseminating the white paper, which will hopefully show you all, how we came to evolve and build a system of care. And along with that, really highlighting the importance of capturing data. I worked on the East Coast, for many, many years at Boston Healthcare for the Homeless program, an amazing organization. And we were always, again, trying to make the case to Medicaid why homeless services are needed and why they need to be funded. So, in terms of data, we started at Illumination Foundation capturing it on Google Sheets. We did not have an EMR at the time. And I'm glad we collected all the data on Google Sheets, because it was that data that really informed our decision-making in terms of how we need to keep building our system to serve people experiencing homelessness. The other thing that we were very early on working with is our partner health plans, because there is commitment from the health plans to take care of this population. But of course, from their perspective, they need to see the return on investment. What is the value of a healthcare system that's built specifically for people experiencing homelessness? So we worked very early on with one of the local health plans who were able to share all of the data that they had on utilization and medical burden. And we were able to combine that with our data and work closely with Dr. Abraham to really use prescriptive, predictive data in terms of analytics to show the risk of this population when they are not getting services, and how we can actually predict future risk and prescribe a care model that works for everybody. We all know we see individuals, that are coming into our care system that not everybody needs the same level of care. If you're seeing 10 individuals, there are 4 that might need the most intensive services. They will need longer length of stays in medical respite. There are others who need to be put in housing first. So how do we use our data to really describe the care model that we are building on as we continue to move forward? So we really used the prescriptive, predictive data analytics to inform our care model, and we continue to do that, and are hoping as we build our system of care that there is that value shown for the work that we're trying to do as we improve care for our clients. Next slide. So how did we get to our system of care? Early on, as Paul was describing, we started off in a motel setting. And over the years, realized that if we were to do right by our population, we really needed to bring services to where they live. We need to be out on the streets. We need to be in the shelters. We need to be in medical respite, do as many services as we possibly can in a location where they reside. So what you see here is this facility that we have built in Southern California, in the city of Fullerton in Orange County, which has 150 beds, and it's an integrated delivery system which provides primary care services, mental health, dental, psychiatry, substance use, along with medical respite beds and navigation beds. So as we were trying to look at where the gaps were, we kept seeing clients coming into our medical respite, but still not accessing primary care. So we, over the years, talked about how do we actually connect them to FQHCs and other systems. And with all our best effort, we knew our clients weren't able to access those services. So we went ahead and built that medical group in-house where we can actually deliver the services to them. And what you see around this circle are these little homes that are called micro communities. And that was another innovation that Illumination Foundation implemented several years ago, which is a hub and spoke model. So we have a 150 bed facility, which is a hub for all the integrated services that people experiencing homelessness need. But then how do we now stabilize them and move them into housing? And we just showed you the street to home care model. So in the micro community model, what we've been able to do is master lease or purchase single family homes, 5-6 bedrooms, where folks that are coming into our medical respite or shelter can now move on into housing while they are waiting to get their permanent supportive housing. I'm sure all of you can attest to this. The average person moving into housing is taking us anywhere from 16 to 18 months to get somebody connected to a voucher. But at the micro community model, we can work with landlords and our clients to move them into the step down model while they wait to get connected into a voucher. Next slide. So we are expanding a lot in Southern California, and here are the facilities that we are operating right now. We are in Orange County, LA County, Inland Empire, and this last photo that you see of Olive View Medical Center in Sylmar. We also have another facility on a hospital campus at St. Jude. This has been our most recent opening of our medical respite facilities on the hospital campus, which really speaks to, again, the need for an integrated system where we can deliver all the services and partner very closely with our inpatient hospitals to really provide the care that these clients need. We're close to about 350 or so medical respite beds here between the different counties, but also know that with CalAIM coming down, which is a Medicaid reform in the state of California, which really is addressing the social determinants of health and bringing housing and healthcare together, medical respite is a key component and will be a covered benefit as part of that program. Hence, you see us expanding medical respite beds. Next slide. So how do we sort of do what we do? It all really comes down to care management, and that is a core component of what California is doing with CalAIM, that we have to have our care team at the center, which is connecting our clients to the medical group, which is our primary care practice. We're addressing the social determinants of health by getting folks into housing. We're using our data to really look at utilization for our clients and see where do we need to move them, what level of care do they need next. Not every client needs the same level of service. And then how do we continue to improve on the care delivery while looking at our data. Next slide. One more. And this one really is so critical, as we know, when we're trying to disrupt the cycle of homelessness and move people into housing, that yes, housing is the end goal, but how do we keep people in housing? Housing retention is really critical. And again, in the state of California, it's going to be a covered benefit in terms of finding housing and then keeping people in housing. So how do we continue to manage them with the case management services that they need so they can succeed in housing, which involves delivering services where they live? Next slide. Again, our care model has really been based on whole person care, addressing the physical, the mental health issues, and the social determinants of health for the most vulnerable folks that we are seeing, here in our state. And the key here is we are looking at data that's really driving our care delivery system. We are, long gone from trying to, let's just try this project before because it's getting funded, but let's use the data to make sure that this project will actually work. And in the end, the goal always is to show that there is an effective care model that works for this population, which is not just reducing cost, but also improving quality. And with that, let me turn it over to Dr. Abraham. If there are any data geeks out there, I can tell you that you will definitely, enjoy this next section, which really will, again, highlight our care model, which is how do we build our care team? What are the interventions we need to do? How do we monitor outcomes as we assess our clients? So let me, at this point, turn it over to Dr. Abraham.
Thank you so much, Pooja. And again, a warm welcome to all those that are attending the session. I represent Foresight Health Solutions, an AI and machine learning healthcare analytics company that has a singular focus, and that is to address social inequities, healthcare delivery challenges through advanced prescriptive and predictive analytic tools and analytic models, with the goal of really helping our communities that are most marginalized and most vulnerable. In that quest, we couldn't be more honored and thrilled to partner with Illumination Foundation, that, as you can tell from what Paul and Pooja have spoken of so far, is just a tremendously powerful integrated model of care, and now using data and data analytics to drive that model, that client-centered model. I always like to start this type of presentation with a quote from someone that I think many of you know, Virginia Eubanks. And she has a very incisive and insightful book called The Automating Inequalities, where high-tech tools can profile, police, and punish the poor. And the quote that she says in that book is, when tech tools profile or automated data tools profile and are used for automated decision-making, but they are not built to explicitly dismantle the structural inequalities that exist, then their speed and scale will actually intensify them, meaning intensify these inequities. And that's a stark reminder for us as we develop and use technology tools to assist these most vulnerable clients, that we are committed to using these technologies to actually address that need and not propagate them further. Next slide, please. In terms of our data approach, our data-driven approach, there's some core principles that drive all that we do. One is that there is a combination and a plethora of data that is necessary to collectively identify and accurately manage the risk of the clients that we serve. Because we live in an environment that is driven by cost pressures, and we're moving very rapidly towards this value-based purchasing model, we felt it was critical to incorporate claims data to indicate or to identify costs and cost savings through the services that are provided. In terms of identifying the risk profile of the populations, we use some of the more standard and traditional tools out there in the industry. In our case, we use the CMS HCC predictive model that is used widely to predict risk amongst very vulnerable populations, particularly the aged. But then we also have our own proprietary AI-based analytic model that does not just use diagnostic and demographic characteristics, but also incorporates social determinants of health into what we know now to be a far more accurate risk prediction or risk identification process. And last but not the least, there is a core principle in our field, in the area of housing and social support services, that was important. We know that sometimes collecting structured data is hard, and it's sometimes sparse. So we have used, again, the power of technology to scour through notes by housing navigators, through case managers, through other supportive staff that they're tracking in their documentation systems, in their EMR. And you can use what is called natural language processing to actually convert notes into structured data elements that then feed into analytics as well. So that's a little bit about our approach. In terms of our analytic methodology, which is the next slide, you'll see that there are two core components that really define that methodology. One, it is a cyclical and very elaborate process, but number two, it is based upon a thorough process of planning that initiates all the analytic work. And that planning is important because it allows us to understand the population that is intended to be benefited by this analytics. It understands the process that is established and the programmatic structure that exists for the services provided. And that process can take time. In the case of Illumination Foundation, it took 3 to 4 months of detailed discussions, interviews, discussions with clients, discussions with the staff, to be able to understand exactly what the intent of the analytics was. And then, of course, it gets followed by data collection, and that can be complex because you're looking at data from multiple different diverse sources. Based upon the data collected, you initiate or start with some insights that are fed back to the operational teams, to the leadership teams, and it is only then through their input that we actually build the models, the actual analytic powerhouses that drive decision-making. It is distributed to the appropriate staff, both at the leadership level and in the case of Illumination Foundation, also at the frontline staff level, to make decisions that are relevant and appropriate for the types of clients that we serve and the services that are delivered. Next slide. What I'll do in this next few slides is focus on 4 key things using data analytics to paint this picture. Number 1, who do we serve and what is their demographic profile? And then I want to present what their risk profile is, or what their complexity is from both a medical as well as psychosocial perspective. Thirdly, I'd like to present how this integrated service model that has been described can impact and has impacted both overarching cost as well as utilization statistics, such as hospitalization and ER visits. And lastly, how prescriptive analytics can be used and is being used to deliver the most impactful and the most optimized services in this very holistic integrated model. So about the population, 50% of the population that was included in the study was from CalOptima, which is the California Orange County Medi-Cal managed care plan. But you can see there's a large chunk of population that is also uninsured, and there's a constant effort to try to move them into the appropriate care areas, whether it be Medi-Cal or whether it be Medicare or other private sources of funding as well. Next slide. In terms of age, in Orange County, you'll see that the majority of patients fall in that group of 25 to 65 years of age. But it is fascinating to see that we are seeing a changing profile of our population. So there is a large percentage of the population that is less than 24 years of age. And there's a growing population that is aging as well, which obviously adds additional complexities both to the risk modeling of the population as well as the appropriate service that is delivered to them. Slide. Race, ethnicity. In Orange County and in the population we serve here, the predominant population is white at 62%, followed by Hispanic Latinos at 13% and African Americans at 11%. This is very different from the population mix in terms of race ethnicity in our other counties. LA County is quite different, and San Bernardino, Riverside is different as well. And also, the next slide. Well, actually, I was going to say there's an interesting dynamic also in terms of gender. 50% of the population we serve is female, which also adds a very unique dynamic to this changing face of homelessness in the communities that we serve. A few words about the risk profile or the complexity of the populations we serve. We've always known intuitively that it's a very challenging population from a medical standpoint, but the diagnostic risk analytics really quantifies that in a very, very meaningful and powerful way. You'll see here that the majority of population have a score above the normal risk level of a population that is a Medicaid, Medicare dual eligible population, which is already quite sick. And the way to interpret this is that if you see 141 clients out of a population in this study of 1,200 or so clients that have a risk score of 4 or greater, that would mean that they are 4 times as risky from a cost and complication standpoint as the average person in the population. So that just gives you contextually, how to interpret this risk score and identify the complexity or the risk level of the service of the population that's being served. Next slide. What drives that medical or diagnostic risk is the complex comorbidities that this population and these patients present to us with. You will see here that 85% of the population have at least 2 or more diagnostic groups. And interestingly enough, 20%, 1 in every 5 patients that are served at Illumination Foundation in Orange County have 10 or more very complex diagnostic groups that are occurring simultaneously. Again, just paints a picture of the medical complexity of the population served. Next slide. What types of illnesses, what types of diagnostic groups do they present with? And what is that relative risk of each diagnostic group is presented in this chart here. You will see that a large number of folks have sepsis, septicemia driven by, perhaps substance abuse, wound infections that have not been taken care of. As you can well imagine, that's a big challenge in the population. But you'll see that there's a lot of common chronic illnesses, coronary artery disease, COPD, diabetes, congestive heart failure, that's driving a lot of the risk amongst this population. And then, of course, not surprisingly, behavioral health, depression, bipolar, schizophrenia, drug abuse, alcohol abuse, those are all very common in this population. And if you look at that red dot for each of those diagnostic areas, that's an indication of the relative risk of each of these diagnostic groups as it relates to the overarching risk for complications and costs and hospitalizations for the population as well. So behavioral health, numbers are high, but even more concerning is that they're relatively high risk in terms of the impact on both costs and utilization. Next slide. Well, on top of all of the medical complexity and on top of all of the diagnostic complexity, we all know that these individuals, these clients that are being served also have intense social needs and social determinants of health. So our analysis also started incorporating social determinants of health into this predictive risk and this prescriptive risk model. And as you can well imagine, that was a hard process because very often we were not accurately capturing or holistically capturing all of the social determinants of health that exist in the populations we serve. So we did a combination of 2 things. There are certain survey tools that are used by housing agencies, by Illumination Foundation to be able to capture social determinants of health. And then because we knew that it seemed as if we were underreporting some of the social determinants of health through those standardized surveys, we also scoured through the notes of the staff that are providing services to this population. And you'll see in many instances, the counts of those identified with these social determinants of health increased quite significantly when we used natural language processing and analysis of these notes to help further identify individuals with those social determinants. So food security, you started with 366 folks out of the cohort of 1,200 in the study that had food insecurity through a survey. But then looking through notes and doing NLP, we found an additional 158 patients that had food insecurity and perhaps didn't feel comfortable disclosing that in a more standardized, structured survey methodology. So that really points to the importance of looking at a very holistic way of being able to identify these elements so that you can get an accurate picture of risk for the population served. Next slide. How does the SDOH factors impact the already pre-existing risk for the patient that is a result of their medical or their diagnostic factors? And you'll see that just for these four SDOH factors, transportation, income, food security, and unemployment, there's some dramatic jumps in the increase in overall risk when you incorporate the SDOH risk factors into the analysis in comparison to just using diagnostic factors. So unemployment is, staggering. The risk level or the relative risk of by including SDOH factors jumps by 100% when you incorporate that factor into the calculation of risk. And mind you, what we are finding also, because we have been looking at this data for a 3-year period, we can actually look at year-to-year analysis and identify that the predictive model that incorporates both social determinants and diagnostic factors will be far more accurate in terms of correctly predicting who that high-cost, high-risk patient is going to be, compared to those models that are currently available in the industry that use just diagnostic or some diagnostic and demographic factors. Next slide. Just as with the diagnostic determinants or contributors of risk, you have variation in the relative risk that can be contributed by SDOH factors. So obviously, in the context of Illumination Foundation's work, a lot of the population is actually homeless. Some are in permanent housing, so they of course get categorized as having some sort of stable housing, but the majority are homeless. And you'll see that drives a huge risk coefficient for the population as a whole. Same thing for transportation. Transportation has been identified as a fairly significant issue, both in terms of the count, as well as the overarching relative risk or the risk coefficient for that particular element. And so this becomes an important area of analysis to really try to help identify where we focus our efforts, our resources, and time in terms of addressing fundamental social determinants of health when you are presented with a population that has so much need. And there's sometimes, all of us in this industry are overwhelmed by just the complexity of all these factors that influence risk. This allows us to do some sort of evaluation and analysis of where to focus and what types of needs we should try to address that would be most significant. Next slide. I'm moving now to how that Illumination Foundation integrated care model actually makes a huge difference when it comes to cost and utilization impact. Because we were studying this data and the program outcomes over a few years, we were able to show that a year before Illumination Foundation's teams were intervening with clients, you had ER visits that were at 4,138 as a whole. And that declined after intervention, after Illumination Foundation intervention by 22.2%. You saw an even greater decrease in the reduction in hospital admissions between the year prior to intervention and the year after Illumination Foundation intervention, a 26.3% decline in hospital admissions. Next slide. What does that mean in terms of overarching costs or cost savings? You'll see that the total cost dropped through interventions done by the Illumination Foundation team by 30.7%. And that's, a massive multi-million-dollar savings over a 2-year period to be able to really show the true value of this integrated holistic model. And in health plan speak, as a per member per month or per client per month cost savings, that's a 22.9% decline in overarching costs. So it's pretty clear that there's a dramatic impact that this type of integrated service model makes when it comes to both utilization reduction as well as overarching cost reduction. But the next slide really moves into this whole category of prescriptive analytics and how that is used to deliver not just overarching savings, but efficient and impactful services as well. As with most social services organizations, there's a wide plethora of different services that are offered in this integrated holistic service model. And Illumination Foundation actually had a list of about 100 different services that their staff are providing through recuperative care and through the various programs within it. But what our analytics found is that there are some services that have a much more significant impact in terms of reducing those costly events, the hospitalizations and overarching costs than others. So for example, behavioral health, just because of the complex juxtaposition of medical and behavioral health issues, by providing behavioral health therapy sessions, you were able to, or Illumination Foundation was able to save $814 per client per month. That's a staggering savings. And you'll go down the list and you'll see medication assistance and counseling has a significant impact as well. Just by involving a multidisciplinary care team with expertise and experience in a diverse set of needs, you have a dramatic opportunity for saved costs. Going down the list, you'll see that some services have less of an impact, particularly in this short-term 6-month post-intervention analysis that was done. So for that reason, we then also looked at a comparison between a 6-month post-intervention period and a 12-month intervention period, which is on the next slide. And this is staggering in terms of the impact of the value of this analysis. What we're able to show that in some cases, some of the services don't have an immediate positive return on investment or a positive impact. But that does not mean that we can stop doing those services, because there is a long-term value. And you'll see, for example, transportation, right? Within the first 6 months after starting to provide transportation for someone that's homeless, you actually increase their per member or per client per month cost. And that is understandable because now they're actually accessing services, they're going to the doctor, they're receiving medications. And so that cost will increase in the short term. But then over time, and you'll see this now in the column that says PMPM savings after 1 year, that transportation and the ability to provide transportation has a positive impact in the longer run over a 1-year period. And so this type of analysis allows the leadership team to be able to make decisions on where to focus on in the short term, to generate an immediate bang for the buck, but also to identify long-term opportunities for impact that have to be done, not because you get short-term value, but because you get long-term sustainable value as well. So this is one part of the analysis that I think is very powerful to demonstrate and show the importance of being able to find where these services are that actually have a deep, meaningful impact in terms of outcomes for the patient, not just at the population level, but as we are doing with Illumination Foundation now at the individual patient level, because each patient might respond and react differently to different service mix. And it allows the staff that are on the ground and in the field to be able to know exactly what menu of services should be offered to be able to generate the greatest result. Predictive and prescriptive analytics just cannot be limited to a one-time study. And it's wonderful to have this paper, but in the quest of delivering continuous value and continuous improvement, Illumination Foundation uses these types of analytics now on a monthly basis to constantly evaluate and to constantly change how their services mix is going to evolve to be able to meet the ever-changing risk levels and needs of the clients as well. And that's where care management is becoming sort of a key component of this process, because it's not a one-time effort. It's an ongoing effort in a continuum that is designed to keep moving the client forward in terms of success, in terms of outcomes, in terms of incremental change that will make their lives healthier and more sustainable. And that's what excites me, because what this is telling me is that through this data-driven approach, this data-driven, continuously improving model of care, the best is yet to come as the Illumination Foundation continues to disrupt and change the cycle of homelessness. So with that, I'm going to hand it back to Paul to conclude.
Yeah, thank you, Dr. Abraham. Hopefully you can see the full array of services. And I just want to leave you with one quote. And oddly enough, it was a quote by the CIA. And it just talks about their attempts to make sense of the world had carried heat, but little light. And, you know, when I was looking at what we were doing in Illumination Foundation, we have passion, like a lot of passion. We still do, but passion without the direction is really difficult. And being able to now make decisions that we can now show evidence-based models for social determinants of health and really explain to not only our payers, but our other customers, and our other customers are our clients and our guests. It is so important that they understand why we're asking them this question, why we're gathering this data, and how we can better serve them, which is our ultimate goal. So with that, thank you so much, Courtney and your whole team, and again, National Healthcare for the Homeless, where we were basically incubated, for allowing us to present.
Well, thank you all so much. That was so exciting and encouraging. I have a lot of questions, and we have some questions coming in from the chat. So one of the things, yes, we will be sending out the white paper, and yes, this presentation will be, and the recording will be made available afterward. One of the things that I just so appreciate about this work is how thoughtful it is, and really the continuum of care that you're trying to provide, really trying to help people exit homelessness, provide really high quality care throughout their entire experience with Illumination Foundation, and the bridging of partnerships between supportive services and hospital participation, bringing in MCOs as well. I think you all are really modeling this for the rest of the country. One of the things that I want to point out, though, is that even though Illumination Foundation is really ahead of the curve in helping lead this work, what this data-driven approach does is it says, if we have limited bandwidth, we have limited funding, where can we make the biggest impact? And that's what's really exciting about this work. I want to just bring up a few. I'm going to stop sharing my screen so I can bring you all up and to field some of the questions from the group. One of the first questions from George, let me just scroll through real quick. Have you worked with any HMIS data as part of the modeling? So the Homeless Management Information Systems. Pooja, could you speak to that at all?
Yeah, so because we do permanent supportive housing, we do have our data in HMIS. And in fact, we are now working on merging that data into our own data warehouse to really kind of look at, the big picture. But that is one of the challenges we all have. We have to document in that system. It's a federal system. And then we have to home grow our own system to meet the needs of our data collection. But with Dr. Abraham's help, we're able to create those mergers to really impact, our care model, but we need to marry the two, and we're working on that right now. That's
exciting. That has been a challenge throughout for many years, but during the pandemic as well, of trying to identify who's been vaccinated, how to coordinate those strategies. So to be able to marry the HMIS data with in-house data is really going to make a huge difference, big impact across many different systems. Dr. Abraham, one of the questions we had from George was, And determining the savings, the total and the per member per month rate, is the cost of providing the services factored into those figures?
That's an excellent question. And thank you so much, George, for asking it, because what we have done so far is sort of an aggregate picture where we have looked at broad financials across the organization. And in the context of that, we have seen that that is still a cost savings, a significant cost savings, as it accounts for the total savings generated through the services. But we are right now completing and in the process of finishing up an additional time study that takes it down to the specific programmatic level. Because staff are doing multiple programs, it's sometimes hard to articulate the true return on investment, which I think, George, is what you're alluding to. So we are in the process of actually doing that type of analysis to demonstrate and show that even when you account for program-specific costs, staffing, infrastructure, real estate, technology, all of those pieces together, there is still significant savings or a return on investment that can be generated through efficient and effective use of our program model.
Thank you. One of the questions was, would it be possible for you to share the surveys that you developed and the strategies for how to actually ask those questions to the clients in respectful and trauma-informed ways? Is there a training?
I believe many of these survey tools are publicly available standardized tools, such as Prepare, which is used to capture the SDOH data. So Pooja, I'm sure you and Paul sort of would respond to that also.
Absolutely. And in fact, I'm glad you asked that question, because early on, like everybody else, we wanted to create our own survey. Like, let's try this milestone survey that we created. And it was really hard to measure progress on that. So we reverted back to, let's go with a validated tool. And we used the Prepare survey, which is, publicly available. So we came to that again. We made mistakes along the way. We want to collect all the data. We want to see, what we can learn from it. But it was hard to do much with that data. And that is why we went back to, we're going to use a Prepare tool.
That's fantastic. And I'm going to just drop a link in the chat regarding the Prepare tool for everyone. One of the things that is wonderful about Prepare is because it is publicly available. There's lots of wonderful ways you can use that information. NAC has made all of it publicly available with toolkits. But there's also tons of national comparative data. Many community health centers are utilizing this tool. And so we're adding to the body of evidence around social determinants of health, which is really exciting. And it's just to me, a good reason to use this validated tool. One of the other questions was, with the predictive analytics, is the social determinants of health data component solely using NLP and key phrases and open text, or do you use other sources of social determinants of health data as well, like Z codes?
It uses a combination of multiple different sources. So we do use Z codes wherever they are accurately captured. And as most of you all know, because those Z codes are still new and we're not used to accurately capturing that within the standard processes of care, we do get limited information to that today. It is supplemented through the standardized assessment tools. So surveys have become a really core element by which you collect standardized objective data on social determinants. And only after we are able to determine that there is still potentially more information, NLP is used to supplement or augment those standardized or more objective data sources. So really it is the combination of those three methodologies that we believe give the holistic picture of social determinant risk and needs.
That is incredible, because I think what I hear constantly from hospitals and community health centers is it's just one more click. And so much of the data can be faulty because we're not getting down to that last one. And so to be able to pull from multiple sources, to me, sounds like it's creating a much more holistic picture and gathering the data that wouldn't otherwise be captured. Or you're not giving the credit for all the work that you are doing with the clients. So to be able to pull it from multiple sources is so exciting.
Absolutely does. I do want to insist that there is simultaneously, as we are doing this NLP analysis, what we're doing is actually asking for feedback from the staff. Do you think, through your NLP notes, it seems like there is an issue that is related to nutritional insufficiency? Would you like us to add that as a coded system or element so that you can actually increase and improve the quantifiable elements that capture risk, because at the end of the day, the payers will be less inclined to agree to sort of this holistic approach unless it's increasing the objective data that is being submitted as part of the claims process as well.
But that's exciting because the frontline staff get that feedback, and it's a continual process improvement.
That's right.
It's not just data that they never see or impacts their work again. So that really helps to drive the frontline staff and motivation for why you're actually collecting that data. So we only have we have about 5 minutes left, and I'd love to hear what's next. White paper is going to come out. We're going to share this wonderful work you're doing. You're running these reports on a monthly basis. What are the next steps for you all? Where are you going to take this work?
So I'll start out because I saw in the chat someone talked about being a small organization, and that's one thing I think as our culture and our mission, we pride ourselves on education and advocacy. And so, yes, we do consult and we do stuff as part of an arm of Illumination Foundation. But I think more importantly, through our 15 years, when we first started to reach out and share material and especially consult, I remember Pooja and I were thinking we didn't really know how to use the consultant because they weren't providers. And so there was that miscommunication. Pooja, myself, and Dr. Abraham, we're providers. We do this work. We work with frontline staff. So that answer would be yes. And we know that smaller nonprofits don't have the budget, but we either by, just do it on our own and or focus on what that nonprofit or company needs so that we can, take care of the client first. But I'll let Pooja and Dr. Abraham talk about the actual data we're doing, but obviously we're expanding in California because of the fact that we built Illumination Foundation to address the social determinants of health, not knowing, like we didn't have them labeled social determinants of health, but we knew clients needed transportation and they needed the obvious housing and housing first. So I think moving forward, it will be expanding, scaling, and really trying to help as many clients and share the incredible work that Dr. Abraham and Pooja have been involved in. And that's our number one goal.
Yeah. Again, this study was based on 1,200 individuals experiencing homelessness. In Orange County, there's about 12,000 individuals at this time that are experiencing homelessness. So our goal is to really continue to build on the system of care to serve a larger set of population and really partner with our local health plans. So if any of them are here, what I hope you're seeing is that there is a way to manage people experiencing homelessness in an efficient way, but it needs integration. And an organization like ours, a community-based organization, which started very much at the grassroots level, that we can and have built a system that can actually disrupt the cycle of homelessness. So I hope on a local and a national level that this gets noticed and that we are prepared to take on 5,000, 10,000 individuals if given the opportunity, because we have now shown from this data that it does work, but we need everybody to sort of work together on it.
Thank you, Pooja. And from my perspective, there's two things that I am excited about. Through this partnership with health plans, we'd love to get more claims data, because as you can tell, the claims data feeds so much of that ability to accurately identify the drivers that are important from the systemic standpoint, which is overarching cost and cost efficiency. So we're really looking to get more of that data. And if claims is not available, we are right now partnering with other organizations that integrate and give us direct data from the hospitals and ERs that at least identify the utilization patterns to help us appropriately manage and predict risk. And then the second component is really moving towards value-based contracts. Traditionally it's been seen as just the medical area that can do this, but we think integrated service models can take on additional risk where there is more benefit and reward for those that are accurately and appropriately managing the risk, but also benefit to the funders, payers, state governments, county governments, to be able to really take accountability for this desire to make our systems more effective and more efficient.
Shauna, I see your note in the chat, and I will reach out to you for follow-up and loop you in so we can definitely support you. And I am a Robert Wood Johnson Culture of Health leader, so absolutely that we're integrated in so many different ways in this work. I want to thank you all so much, Pooja, Paul, and Ashish, for sharing this incredible work. Thank you for the work that you're doing and leading at Illumination Foundation. Thank you all for joining our webinar today. I will follow up with everyone and send out this amazing white paper so you all can dig into the data a little bit more and share it with your community. And please reach out with any questions. And we're just grateful for you all here at the National Institute for Medical Respite. So thank you. Have a wonderful day.
Thank you.
Thank you.
Thank you.